Welcome everyone. It's a pleasure to be a part of the live stream community education classroom. My name is Damien Richardson. I'm an orthopedic surgeon who is foot and ankle trained, and I'm here today to talk about common foot and ankle problems in arthritis. So today we'll have a PowerPoint presentation, and if you have any questions, please feel free to type them in the chat box. So we'll go ahead and get started. Our agenda for today, we'll start with a brief background on myself. We'll talk a little bit about foot and ankle anatomy, inflammation and arthritis, what it looks like, what it is and what it looks like. We'll talk about a progression of foot pain using the Grand Rapids classification system. We'll talk about the non-operative options for foot and ankle pain, as well as the operative treatment for end-stage ankle arthritis and minimally invasive surgery. So a little bit about me. I attended Arizona State University for my undergraduate degree in bioengineering, where I was pre-med. Unfortunately, my medical aspirations were put on hold. I attended ASU on a football scholarship and was fortunate to be drafted by the Carolina Panthers in Charlotte, North Carolina. My career had a few injuries, was cut short and went to medical school thereafter at UC San Francisco. Towards the end of my medical school career, I actually was interested in clinical science and went to Harvard to obtain my master's in public health with emphasis in biostatistics and epidemiology. I then, after I left the public health school, I went to orthopedic surgery residency at the University of Arizona, College of Medicine, Phoenix. And then fellowship was with the Harvard Mass General Program in foot and ankle surgery. And then here I am today at Hoag, Newport Beach. So the scope of my practice, I like to say my practice includes everything below the knee, from the toes to the tibia. I do deformity correction, including bunions, hammer toes, flat feet, sporty injuries, including cartilage defects, ligament instability, Achilles tendon ruptures. Of course, I do trauma, all types of fractures of the ankle, calcaneus, and the toes, and degenerative conditions, end-stage arthritis of not only the ankle, but the forefoot, midfoot, and hindfoot. So we're going to next get into anatomy. I think the foot is fascinating. There are 28 bones and 30 joints that come together to support forces 3 to 4 times your body weight. Unlike these simple ball and socket or hinge joints, like the hip, the knee, and the shoulder, the foot works in a specific order to maintain balance, function, efficiency, and a pain-free gait. Many people would argue that the hand rivals the foot in complexity. Actually, the two have a similar embryological origin and development. Some people, mostly hand surgeons, will go so far as to call the foot the dumb hand. And it is true that the foot lacks the dexterity your hands do in space, but you can't walk on your hands, at least not very far, unless you're a strong guy like this. Or you have a genetic predisposition to walk on your hands like this guy. Or you're a wee little one like this guy. This is my son, Malcolm, about 2 years ago. The truth is that the hand lacks the durability, complexity, and mechanical superiority of the foot. So when we think about the foot, we break it down in 3 main parts. The forefoot, including the toes and the metatarsals, the midfoot, that includes the cuneiforms, the cuboid and the navicular, and the hindfoot, which includes the talus and the calcaneus. Together, these groups come together and essentially form a tripod. A well-balanced tripod or foot distributes weight across 3 points: the heel bone, the calcaneus, the big toe, and the little toe. The shape of the tripod naturally creates 2 arches within the foot that are key for stability. There's a longitudinal arch that travels from the calcaneus to the toes, and there's also a transverse arch that travels from the midfoot to around the level of the metatarsals. When body weight is added to load the arch, force is distributed along the bones that make the struts of each arch. Here we see an example of the arch on the inside portion of your foot. That figure on the right shows the metatarsal for the big toe, its adjacent cuneiform, the navicular bone, the talus bone, and the heel bone. We see that the forefoot, midfoot, and hindfoot must work together to maintain form, function, in order to support our bodies. The bones aren't the only weight-bearing structures in the foot. Soft tissue attachments, such as the plantar fascia and ligaments between the bones, also contribute to the shape and strength of the arch. A standing imprint on the right, or podogram of the foot, can tell us a lot about where the pressure points lie on a person's foot. The dark spots correspond to areas of high pressure. Picture A through D tells a different story about foot pain for each one of these patients. I think this is a great slide that demonstrates our foot does not operate in isolation. As an orthopedic surgeon, I take into account how the spine, hip, knee, and ankle are all interconnected. This gives me insight to how to best treat problems that affect not only your gait, but your foot as well. Now on to inflammation and arthritis. Inflammation is the root of all evil in orthopedics. Throughout every medical specialty, inflammation is given the suffix itis. In the appendix, it's appendicitis. Conjunctivitis is eye inflammation. Myositis, well, you get it. Arthritis is inflammation of the joint. Arthritis, when it has underlying cause, is classified as secondary. These are hereditary diseases such as rheumatoid arthritis with an autoimmune component, infections that can eat away at the joint cartilage called septic arthritis. Young people, like I once was, who consistently beat their bodies up or have traumatic injuries, can go on to have post-traumatic arthritis. However, degenerative arthritis with no known cause is called primary osteoarthritis. This is an X-ray that illustrates our point. This is called hallux rigidus, otherwise known as arthritis of the big toe. Arthritis affects each joint the same throughout our bodies, whether it's the spine, the knee, the ankle, or the foot. The process is the same. Primary or secondary arthritis has the same end result, which is joint destruction. It typically starts with things you can't see, like microscopic cartilage loss. This then creates synovial inflammation. Then you get thickening of the joint. And on the right, you can see the arthritic joint, and you can see the skin is thicker on the outside portion of the foot compared to the image on the left. We also see the joint space narrowed at the great toe on the right compared to the other adjacent toes where the joint spaces are maintained. And then you get subchondral bone changes and bone spurs. These are all part of the arthritic process. So now let's talk about how our foot progresses with pain. Now, it's not important to read all the words on this page, but there's a very successful group of foot and ankle surgeons in Grand Rapids, Michigan, and two of them are actually former presidents of the Foot and Ankle Society. They devised the Grand Rapids classification. It helps us understand how there can be a sequential progression of disease within the foot. It starts with tightness in the calf, which creates an imbalance within the foot. This can manifest as common things, such as Achilles tendonitis or plantar fasciitis. There is then overload of the structures of the forefoot and the medial arch. This then spreads to the midfoot, the longitudinal arch, and the transverse arch. Finally, the hindfoot and ankle breakdown. We'll go through these individual concepts with X-ray examples. First off is Grand Rapids 1. This is a soft tissue problem. Here in picture A, you see the arch is still the arch is still maintained, and the alignment is well at the first metatarsal. This is Grand Rapids 2. The arch is intact, but deformity is beginning at the forefoot with a bunion and arthritis at the big toe. You start to develop hammer toes and crossover toe deformities. This is Grand Rapids 3. Now you're beginning to see the arch collapse in both the transverse and longitudinal planes. You're beginning to have progressive disease noted at the bunion and the lesser toes. This is Grand Rapids 4. The hindfoot joints are affected. These are the circles. By the time you get to this stage, it's hard to distinguish the pain between your foot and your ankle. This stage is associated with pronation or rolling into the foot and increased wear on the inside of your shoes. Patients typically have weakness pushing off their toes or doing simple things like a heel rise. Finally, Grand Rapids 5. This is the stage where the ligaments of the ankle succumb to the tension of the rolling foot and the ankle becomes arthritic. Here on the figure A on the right, you can see how the medial portion or the inside portion of the hind foot is more in and that foot is angled outwards. You also see that the joint at the ankle joint is asymmetric, where it's more joint space on the inside and less joint space on the outside. So let's talk about our non-operative treatment options. No matter what the joint is, non-operative management orthopedic surgery typically involves one of three things: limiting the force through the joint, limiting the movement through the joint, or minimizing the pain response to inflammation. Most of my patients pick a combination of things that work best for them. These things include braces, which are designed to limit motion, orthotics that absorb force, a cane that can reduce the force through the limb, weight loss. People don't understand that 5 pounds of weight loss can lead to 10 to 15 pounds of less weight on each step. Physical therapy. These are exercises designed to keep joints from getting stiff, strengthen the supportive muscles, and stabilize joints. Activity modification. Low impact exercise can't be emphasized enough. Doing things that don't cause excessive force on the joints, like elliptical machines or exercise bikes. Anti-inflammatory medications and Tylenol. These are great things to minimize the pain response, but you should discuss these with your surgeon or your physician before starting. And then steroid injections. These are great local inflammation reducers. They can be effective for up to 3 to 6 months. However, they can also have side effects, such as tendon ruptures and steroid flare. These are important to discuss with your surgeon as well. And finally, one of my go-to options for the foot is a stiff sole with a rocker bottom contour. So let's talk a little bit more about stiff sole rocker bottom contour shoes. The normal gait starts with heel strike and ends with toe off. The force of our body weight places stress across specific points of the arch during different parts of the gait cycle. A stiff shoe makes sure that the beginning, middle, or end of the gait, not one part of our foot is experiencing a peak force. The stiffness of the shoe and the rounded bottoms help disperse the force across the length of the foot. So, shoe wear choices are critical for many of my foot and ankle problems. A shoe like a Nike Free or a minimalist type shoe is great if your arch looks like figure A. If you have foot pain, or if your arch looks like figure B, you probably would benefit from a shoe with a stiff sole and a rocker bottom. This prevents you from bending through those joints that are weak and already painful. Bracing. Bracing is another big thing that I do in my clinic. Bracing options have come a long way in foot and ankle. Although the classic Arizona brace on the left is still my go-to. It's light, custom molded, easy to fit in a shoe, and stabilizes the ankle and the hind foot. Braces have evolved with materials and mechanics to effectively take the weight off the ankle. The three examples on the right are a patella tendon bearing brace, a PTB brace. These unload the ankle and also provide excellent immobilization. So now let's move on to operative treatments. We don't have enough time to discuss all of the operative treatments for the foot and ankle, so we'll focus on the ankle today. In particular, we'll discuss operative treatment options for end-stage ankle arthritis and minimally invasive procedures. So, first, what is end-stage ankle arthritis? If you look at these pictures, from the top left to the bottom right, there's a progression of arthritic change. And you see at the top picture, there is normal joint space, no sclerosis, and there is pretty much symmetrical joint space. If you fast forward and get all the way to stage 4, the joint space has been obliterated and there's complete bone-on-bone contact. That's the level of arthritis we'll be discussing today. So, for end-stage ankle arthritis, what happens when conservative options fail? Well, essentially, you have two options. You can either replace it or fuse it. Both camps have evolved significantly over the years with plenty of options to choose from. Total ankle replacement has gained momentum over the last decade with a number of manufacturers with FDA approval in the US. This particular model by Wright Medical has been one of the leaders in the field. They use a CT scan with 3D printing technology to make patient-specific instrumentation for use during the procedure. This makes very accurate placement of all the parts. However, there are no minimally invasive solutions for total ankle arthroplasty. It takes a big incision to put those components in. Even though ankle replacement has made significant strides with improved outcomes, ankle fusion has been the historic gold standard for end-stage arthritis. Similar to total ankle replacement, fusion was typically done using large open exposures through an anterior approach. This allows for sufficient access to access the ankle joint and remove the remaining cartilage. However, the goal with every fusion surgery is to obtain bone-on-bone contact and compression at the joint surfaces for the bones to unite. For an orthopedic surgeon, the smallest decisions we can typically make are with an arthroscope. Arthroscopy has been around for many years in big joints, such as the knee and the shoulder, and has had very good outcomes. Foot and ankle is becoming more familiar with arthroscopic techniques as instrumentation continues to evolve for smaller spaces we encounter. Of the options for ankle fusion, only one is useful for minimally invasive arthroscopic procedures. That are screws. Cannulated screws are the implants of choice for most arthroscopic ankle fusions. Technological advancements have made primarily with the tools that allow us to technological advances have been made primarily with the tools that allow us to work in small spaces. X-rays are used during the procedure to place wires with precision, and the cannulated screws are then placed directly over these wires using small incisions. Here's an example of various portal sites for arthroscopy. These procedures are all done with 3 to 4 small 1 to 2 centimeter incisions. An understanding of the underlying anatomy is crucial to avoid damage to surrounding structures. For example, portal B is an anterior access point. It's adjacent to some of the important structures such as the extensor tendons of the foot. This is a typical setup with a traction device attached to the ankle, pulling on the ankle gently to create space for the instruments. There's a monitor in the background for viewing. Instruments include a shaver, scope, and portal for irrigation. Arthroscopic views of the joint are provided that shows the cartilage in the shaver. Next to it, an arthroscopic view shows the cartilage being removed. Cannulated partially threaded screws are then placed percutaneously over the wires. Multiple configuration, different types of cannulated screws can be used. So summarizing operative treatment, whether the pursuit of fusion or replacement is a very patient-specific endeavor. It's a long conversation you should have with your orthopedic foot and ankle surgeon. In general, patients are equally satisfied with both fusion and total ankle replacement. Studies have demonstrated with ankle fusion versus arthroscopic fusion versus open procedures typically are equal in terms of the fusion rate. However, with arthroscopic surgery, outpatient surgery, pain is improved, complications are decreased, and outcomes at 2 years are improved. Thank you.
So no questions.
Oh, thank you, everybody. It's been a pleasure being here. Hopefully you found this educational and